any doubts that you have got from the last class myasthenia? I've been uh, trying to solve as many doubts as possible in the Facebook club, but some of the posts are still unanswered today because it happened to be a Sunday, and a lot of homework was to be done from my end. So we'll be answering it. Okay, and any query that you have for the today's class also at the end, you can join me on the Facebook club there in a post, and don't tag me anywhere else, and I'll be putting a post by the class ends, and then we can solve all your doubts there. Daily it is going to be 7:30 p.m. Okay, daily it is going to be 7:30 p.m. class. Uh, there was a query by every student yesterday. I focused on this query that the myasthenia which kidney nerve is least frequently involved, and I answered it as 9. See, ninth is a predominantly sensory nerve. 10th is a motor and sensory both. So when you look at the 10th kidney nerve possibility of an involvement, a patient of myasthenia could easily come to you with a dysphagia complaint, right? One student is telling me our mess closes at 10 p.m. sir. Oh, sorry for your food. If you are, you can sit in the mess and attend the class there itself. Eat the food also. There's no harm in that. Okay. Oh my God. Someone has posted a very big snake today. Oh my God. That's the problem with the chat box that we have. From where to read the CNS practical? You can go and read it in Hutchinson if possible. I found MacLeod to be a better one, but still, if you want to have a clinical view that how all these reflexes and testing is done, you can see on the eMedicos app we have a special practical course for medicine, in which for neurology I've done a lot of work. More than an hour video is there, and in the rest of the system Dr. Arvind sir has done it very well. Okay, so you can have a look on that. Class will be till 9:30. Why is immunosuppressive drug given after thymectomy? I was clear on this concept yesterday, that the antibodies, the acetylcholine receptor antibodies, are of the type IgG. That means if at all formed, they are going to remain in the patient for a pretty long time. Got my point? So I should always give an immunosuppressant even after thymectomy for a reason. Whatever antibodies are there already in the patient, they should not go and destroy the receptor. That means thymectomy will remove the source of the antibodies, but giving an immunosuppressive after it will further delay the progression and might be. And we have seen patients of myasthenia, most of them, after the age of I think so 60 or 75, 70, they are totally a person who is without any treatment, just some pyrodos treatment they require for maintenance therapy. And a good example of myasthenic patient, I hope you know this, is Big B Amitabh Bachchan. He got diagnosed with that, and he did not get a thymectomy done because it was just an ocular myasthenia gravis for him, and they just managed him on pyrodos treatment and he did very well. Okay. Need a holiday for a preparation. So what are you preparing for? Opening of the lockdown. Okay, I asked my kids, what will you do after the lockdown opens up? They all said me only one thing: we're going to go and eat ice cream somewhere. My kids at home are not getting ice cream, Kinder Joys, and I know they are having a lot of malnutrition symptoms and withdrawal symptom of all these things. See, I was seeing a lot of posts, angry posts from your end also, that students want a break, They want one subject to be done in a day and all these things. I'll tell you one thing. This lockdown period for studying is a most peaceful period. The no cinema hall is open, no cafe coffee day is open, your library is also closed. You cannot go to your friend's place and a friend cannot come to your place. So you cannot chit chat and just waste time. So this is the golden time. Please study. And this is a very peaceful time. You go out and see, you can breathe fresh oxygen. Yesterday I told you in Delhi pollution is so less that even orthopedic surgeons can read ECG. Okay. See, folic acid supplement in a pregnant female is given pre-conception nowadays. In a female who is on an anti-epileptic drug, we try to give the folic acid supplements as soon as possible whenever she comes into my OPD. Yeah, what is status migraines? I've answered this on Facebook also. Status migrainous is a migraine patient whose migraine headache is not responding to medical line of therapy, and most important, the part of definition, it is beyond 72 hours. See, if you remember the duration I mentioned in the Puma, above that duration, the diagnostic criteria for migraine, it was 4 to 72 hours. Okay, 4 to 72 hours was the duration. If it is beyond 72 hours on treatment, of course, it is known as status migrainous. Look at these status. Status epilepticus, seizure more than 5 minutes, if you remember. Interictal LOC more than half an hour. And status migrainous beyond 3 days time. Okay, I'll start the class. So that's your favorite Bollywood star Shahid Kapoor, and a remake came, Kabir Singh of Arjun Reddy, a masterpiece. We copy paste our movies from Tollywood most of the time. Okay, so we did this mistake again, but it came out to be a nice movie, no doubt. Now in this lockdown period, if Preeti asked Kabir, please say me 3 golden words, he would only say one thing: go Corona, go. Okay. And people who have just joined me, someone who is very happy and I really like all his acts anytime is our Mr. Beans. He is wishing you one thing which you forgot today. It's a Sunday. So April is the only month which has got maximum Sundays. Why? Because every day was a Sunday for us this time. Okay. So happy Sunday to all of you. Let's try to celebrate this Sunday with a different kind of a thing. Of course, the thing that you like the least to do on a Sunday is to study. And thanks a lot for coming for this session, first of all. Right. Now let me start it with a very simple concept of CNS infection. There are a lot of CNS infections with us. Now what are the CNS infections and how do they really behave? Now let me start with the simple one, that is a bacterial or a patient with pyogenic meningitis. So there's a patient with me with bacterial or pyogenic meningitis. Okay. Now see this topic, if you go back and read in Harrison, you will really get some kind of infection from there. Because I myself found that this topic was really stressed too hard. But for the exam purpose and even for clinical purpose, you should know only few points out of it, because not all kind of CNS infections are there. Now look at this. The most common cause of pyogenic meningitis, when I look at the most common cause of pyogenic meningitis, when I look at in the age group which I know as the adolescent, okay, as well as in a different age group which we consider as adults and the elderly patient. What are the causes of meningitis as per the age group? This is the very first question. Now, if you remember in adolescent age group, when I look at, it's Neisseria meningitidis. Also nickname in all the microbiology and medicine books as meningococcal meningitis, a very famous one. When I look into the adults and the elderly population, it is strep pneumoniae or pneumococcal meningitis that we know. So there are two types of meningitis as per the age group. We try to define the organism causing it. Now another group of question which has been very frequently asked is this: Most common cause of meningitis that is pyogenic. When I look into an epidemic is a meningitic phase in which it is spreading quite fast. So it's occurring in a very rampant way. It's an epidemic. If I look at the epidemic of meningitis, it's meningococcal. Then we have this most common cause of community acquired meningitis. Now, if you know this term community acquired, that means it is in the community irrespective of the age group that we look at. So most common cause of epidemic pyogenic meningitis is meningococcal, no doubt. But when I ask you community acquired, I don't take the age parameter, neither I look at the epidemic phase. It's none other than my pneumococcal. Okay. So these are 4 MCQs I've tried to solve them. And sorry for the boxes again. I'll try to cover it up. Now, few facts to know about each one of them. Only few facts I'll tell you. First, I'll take out this pneumococcal. A lot of questions have been asked on it. See, around 50% of cases of meningitis, are pneumococcal. They say that 50% of cases of meningitis in the world, also everywhere, is always a pneumococcal meningitis. So we should think about this first. Now, what are the risk factors? What are the risk factors to think about a pneumococcal meningitis? There are very few important risk factors that we all should know about. Now, in the risk factor, when I look at, it is a pneumococcal pneumonia. Now, I'm not writing pneumonia again. I'm writing a pneumonia which is due to this particular organism, pneumococcal. Okay, that's a pulmonary infection and could be even a chronic infection in the sinus or maybe ear. So I'm just writing a layman term, like you can consider it as sinusitis chronic or maybe otitis. Apart from this, we find it very frequent in diabetic patients also. In people who have got splenectomy done. Okay. Then in patients with hypogamma, now it's the gamma globinemia. So in people with splenectomy being done, hypogammaglobulinemia in diabetic patient, we think about it. Okay. Then of course, don't forget head trauma and fracture. Head trauma as well as head fracture or skull fracture. These are another predisposing or rather risk factors, okay, that we consider for this kind of a meningitis, right? Now, when I look at this pneumococcal again, remember a MCQ on this being asked. Pneumococcal meningitis is the most common meningitis or most common cause of meningitis after a CSF leak. Okay. So after the CSF leak, when I look at the meningitis with the causes, then the most common cause is again pneumococcal. Okay. I'll repeat it again. Some people have joined late and some people are having issue with the hanging. In my internet at the speed of normal 4G, it's clear there's no black screen at all. So please check at your level. Some problem must be there in the app or maybe the network. All is well at my end. Pyogenic meningitis, the most common cause, adolescent age when I look at, is meningococcal meningitis. In epidemic also, it's meningococcal meningitis. Adults and elderly, it is pneumococcal, right? A community acquired meningitis, when I look at in the community itself, overall is always a pneumococcal. 50% of people with meningitis happen to be seen as pneumococcal. Risk factor for the pneumococcal meningitis when I look at is a pneumococcal pneumonia in the lung, chronic infection. Okay, I'll put it in a different way, more scientific. It was sounding like a layman. Sinusitis and otitis. So infection in the sinus in the ear can also be a risk factor for it. Then we have diabetes, splenectomy, hypogammaglobulinemia, head trauma and head fractures. Okay, any skull fracture. Please remember this age-old MCQ. The most common meningitis after a CSF leak that we come across with is none other than my pneumococcal meningitis. Okay. Just a word on meningococcal, not too much of detail, but we should know this fact that 25% cases of meningitis when I look around, 25% cases of meningitis when I look around are due to meningococcal infections. CSF leak means, oh God, it's a very simple concept. If you know CSF is in the brain, outside the brain, in the subarachnoid space. You must have heard the term as CSF rhinorrhea, I'm sure. That we did a operative procedure and the patient started having a lot of secretion in the nose. And those secretions were not the nasal secretion, they were the CSF secretions. So the cribriform plate, which is a very fragile area, can easily break through in any kind of a head injury or maybe an operative surgery on the cranium being done. So CSF leak, when I look at happening in a patient and meningitis coming in them later on, the most frequent cause is pneumococcal. Simple. Meningitis. 25% cases of meningitis are meningococcal meningitis. Don't forget this fact. And just a fact which I could read from Harrison is that they come in epidemic. They come in epidemic every 8 to 12 years time. So every 8 to 12 years time we find an epidemic coming for the meningococcal meningitis. That's a very important thing. Don't forget this word. Epidemic meningitis, whenever seen, is due to a meningococcal meningitis. So this is the framework of the concept of pyogenic. What are the causes and what are the things related to it? Yeah, overall the most common cause is pneumococcal. Just a question comes, a patient who comes to you with a bacterial meningitis, overall the most common cause is always a pneumococcal. Okay. Remaining 25%. Now that's a genuine doubt. So what about the remaining 25%? Is listeria. Now I'll not go into every organism which can cause meningitis. I'll just deal with few ones which are very important for the exam purpose. As I was telling, this topic CNS infection has a lot of facts in it. Like we're dull with Caesar, everything, it has more of logic. Somewhere here there's a lot of facts here, but it's a very high yield topic. Remember this year itself in NEET PG we got 3 questions or 4 questions on CNS infection and 2-3 questions on headache. So topics which I myself thought were very difficult to teach because this was more of fact there, are more commonly asked there in a clinical way. Okay. Now look at this listeria. Listeria is commonly seen in few group of people which are neonates and elderly. Okay. And even in people who are to some extent immunocompromised. And in pregnant females. Pregnant females. Or I can just put the word as pregnancy there. So in neonates, people who are less than 1 month, and elderly above 60 years, if I take the age group, immunocompromised and pregnancy. So they are more predisposed to them. So who are the people who are predisposed, or rather a host for the listeria organism? Are the neonates, elderly people, immunocompromised and pregnant females. Okay. Now, how do you get this listeria infection? Like if you understand this, meningococcal, if you read in microbiology, it comes through the aerosol route. The pneumococcal can also come through the aerosol route, but listeria comes through a different route. Now remember this, listeria is ingested in infected food items. Infected food items can bring in this organism in me. Now what are those infected food items which can come with it? Coleslaw, cheese and milk. So coleslaw is a kind of a thing which is kept in the refrigerator. It's part of a salad dressing that we use in the salad. Okay, if you go to Subway, you know that kind of a thing that they keep on asking you what to put, what to put. I put everything there. I make it a Rajasthani thali. My burger of Subway is like a Rajasthani thali. Everything is inside it, full of nutrition. So coleslaw, cheese, and the milk are the three things which can bringing this bacteria to me, Listeria. Okay. So we have three organisms: meningococcal, pneumococcal, and Listeria, and few facts related to them. Now, clinical features. Clinical features. Clinical features. When I look at the disease proper, it's a triad. It's a love triangle. It's a love triangle. Okay. So a love triangle is like this. Here it's a fever, headache, and neck rigidity. So there are three things like fever, headache, and neck rigidity, which are the theme which are together to make a pyogenic meningitis like thing. This has been asked last year, 2019. I remember in NEET PG, this was a favorite question. What is the triad to call it as a meningitis? Okay, staph aureus, someone is asking me about that. I'll come to that separately. When I go to the treatment part, it's better that I tell you a few points on staph there. Okay. Plus, oh, sorry, I wrote the neck rigidity. Plus, altered sensorium is also very, very important in the patient. Altered sensorium. Okay, so these are the four points which we need to know about the patient of meningitis who comes to me. Please do remember there are two clinical signs which I'll show you the images also. One is the Cunning's sign, and the second one is the Brudinsky. Cunning's and the Brudinsky sign, which are the two signs that we come across in a patient with meningitis. Okay. Now, what are these signs? Let me show these signs to you. That's really better from there. Okay, got some image, taken it from the net. Look at this patient now. In this patient, we are trying to keep him supine on the bed. We are trying to flex the hip, and the doctor on one end is keeping the knee joint also flexed. And suddenly, when the doctor tries to extend the knee joint from this kind of a flex posture, the patient starts getting a lot of pain in this. Okay. Another one is this, in which we try to flex the neck, and then there is a simultaneous flexion of the hip joint also seen. So there are two signs that we elicit in them. One is a patient who is lying down supine in the bed. We try to flex the hip and the knee, and we try to extend the knee at this point, and there is a sudden pain felt. While in this side, we try to flex the neck and the knee automatically flexes here. Okay. So what are these signs? What is A and what is B? Can you tell me that? Let me check your knowledge on this. What is A sign and what is B sign? Okay, who is a Brudinsky sign? Yeah, someone has answered it correctly. A is a Kerning sign and B is a Brudinsky sign. So A is a Kerning sign and B is a Brudinsky sign. Yeah, just checking the spelling of Kernings. Actually, I just forgot that. Sorry, I'm from Hindi medium, so there's some problem with my English. English is always my half girlfriend. Okay. So you should know these signs. They're very simple. It's clear in the images also. But why do they happen? Now, this is a very important concept. When there is meningitis, it's not only into the brain region. The meningeal layer covering is also in the spinal region. So when you flex the neck, you'll have a flexion of the hip also. Because of the meningeal irritation, it's all connected to. So whenever the meninges is irritated, the whole pain tries to refer from the head to the spinal region. So like in this case, we are trying to flex the knee and flex the hip, and then we try to extend the knee. And suddenly we find there is a lot of opposition done by the patient, and the pain occurs in the patient. Because the meningeal layer which was there here, maybe in the back region, is being stretched by doing this kind of a maneuver. And suddenly patient will find a lot of pain. Same goes here. If I try to flex the neck, there is flexion of the hip and the knee joint also. So we have this kind of a problem because every meningeal layer is connected together like this. It's not going to the leg region, I agree, but at least into the spinal region. Okay. So just know the image and the sign which are associated with it, Kerning and the Brudzinski sign. Very simple. Now moving on to the clinical features, another very important one is seizure disorder. Now people with meningitis can present to me with seizure also. Okay. In seizure disorder, what you find is that around 20 to 40% of patients with meningitis have presented to me with seizure also. Where is the pain? Pain is in the knee joint, or the patient will complain of a vague pain. See, what we are trying to do, we are trying to stretch the meningeal layer by causing some kind of movement in the joint. See, if I flex the neck and the meningeal layer there is inflamed, I'm going to also have flexion of the hip because the meninges are all inflamed. It's all connected with each other. So when I flex the neck, the hip also flex. That's the Brudzinski. Okay. Kerning's, what we have, when there is a flexion and I try to do the extension, again there is a irritation in the meningeal layer and the patient complains a lot of pain. Okay. Seizure occurs in not all patients, just 20 to 20%, 20 to 40% patients with meningitis. And we find this, that seizure whenever happening in these patients require a further investigation. Why? One is ischemia. Remember, if there is ischemia in the brain, you can have a kind of seizure also. Then due to cerebral venous thrombosis. Due to cerebral venous thrombosis, again we can have this kind of a problem. And of course focal edema that we find in the brain. So because of meningitis, there can be focal edema, there can be cerebral venous thrombosis, there can be ischemia, anything can happen. Okay. Okay, now a student asked me, sir, will it be positive in every patient of meningitis or no? I'll come to that. You know, even neck rigidity, Kerning's and Brudzinski has got a limitation. Write it down. Kerning's, Brudzinski, or even the neck rigidity is absent in some kind of people who are very young, and in fact even elderly people. Or maybe immunocompromised patients. Now IC stands for the immunocompromised patients. So remember this, whenever there is an immunological reaction, then only that whole thing of meningitis or the inflammation of the meninges is going to happen. So if the patient is immunocompromised, the meningeal inflammation is not that much. So remember, in very young and elderly people, why in very young? They are not that immunologically active to cause that much inflammation. In elderly also, as the time progresses in life, the immunological reaction delays or is not that flared up like any young patient with meningitis. Okay. So in immunocompromised, elderly, very young, all these signs could be often absent. Now, let me look into a very important thing. How do you diagnose meningitis? This is all clinical, which I'm talking about. I'm also going to do a CSF analysis in them. CSF analysis, okay? So remember a few points about this. CSF analysis. How do we do? Remember, as a protocol goes in for that, we have to drain around 20 ml of CSF for doing this, known as diagnostic lumbar puncture. Now I'm using the word diagnostic lumbar puncture. That means I'm doing an LP, taking out the CSF, and I'm draining out 20 ml of CSF at a single point, at a single time. Now remember this, when I take out this 20 ml of CSF, I divide it into various vials or the test tubes that I have with me to carry them to the lab. There are 4 vials that we try to divide all these 20 ml of fluid. First, second, third, and of course the fourth vial. So what is the rationale of trying to do? LP stands for lumbar puncture. In doing a diagnostic lumbar puncture, I drain out CSF 20 ml and I take it to the lab, not in a single vial, I take it in at least 4 vials. That means I have to divide it as 5 ml each. Now what is going in the first vial? What I tell the lab people, this is the first vial and what they should check inside it. Remember this, in the first vial, we check for glucose and the protein content which is there in the CSF. So the glucose and the protein content in the CSF, what is the normal glucose, what is the normal protein, I'll come to that later. But the content of the glucose in the CSF is always sent in the first vial to the lab. Second one, remember this, the second vial that we have, we're going to send their culture and staining. So culture and staining of the CSF sample to look out for the type of bacteria that we are growing inside it or we are having the problem because of that is always seen in the second vial. Now the third vial is always good for looking for a cell count. The normal CSF cell count is always seen in the third vial. And the fourth vial is a vial that I keep with me preserved in the lab. I keep with me preserved in the lab, okay, for any kind of an additional test that I like to do. So any kind of additional test I might require to be done later on, I can send it in the fourth vial because it's already there in the lab. Okay. Now why did we do all this drama? I should have sent everything first vial, second vial, and they could have done in 20 ml specimen. See, the problem is, just imagine this. You do a lumbar puncture, and who does a lumbar puncture in the ward more frequently? Intern. And most of the interns, even in my internship, I've done this drama. We end up doing what? A traumatic lumbar puncture. That means we have pierced the needle through the skin into the subarachnoid space. While going there, I've punctured a vessel and that blood leaks into the subarachnoid space. So in a traumatic LP, what are we going to get? A lot of blood with the CSF. That means a lot of RBCs with the CSF are going to come there. Now look at this. When I'm collecting, now look at this. I'm collecting the CSF. I'm collecting the CSF in a serial order. First vial, second vial, third vial, fourth vial in a serial order. Obviously in the first vial, when I look at, the RBC content will be the highest if it's a traumatic LP. Second, third, fourth, relatively less. Now I'm more bothered about this point, cell count. Why? See this. If the cell count, I look in the cells which are lymphocytic or maybe neutrophilic cell in the CSF. And now it is all mixed up with the RBC. So it's for the pathologist very difficult to tell me the actual cell count because it is full field of RBCs there. Maybe below the RBCs the cell are actually been hidden. So obviously in the first, second vial we are going to have higher amount of RBC. In the third vial the RBC content is going to decrease down. So the cell count is better seen in the third vial. Okay. Now just remember this because this year, last year, every year we get a question on this small topic. I always remember like this, in first year MBBS, glucose and protein, if you look at, this will go to the Department of Biochemistry. We are looking at the biochemistry profile. Culture and staining will go to which department? Microbiology. So look at this, in the first year, we were reading biochemistry. Second year MBBS, we were reading microbiology. Third year, we were just counting the years left. And fourth year, we were studying more. Or we were just relaxing preserved. So that's a very simple mnemonic to remember all these things. Now, what is the CSF picture in a normal subject and how do we compare it with pyogenic meningitis? Let's look at this first. CSF analysis. No, 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 no. Someone is asking me a doubt. No, 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 no. Not 80 ml CSF. If you take out 80 ml CSF, his life will become dry. He'll live a dry day all throughout his life. Total. So if you want to take it total, so total 20 ml of CSF is drained out. Common sense, 4 vials you divide it as 5 ml each, not 80 ml. Okay, don't take out that much of CSF. You'll have a dry life all throughout his life. Now CSF analysis. CSF analysis, when I look at a normal subject first of all, and I would like to compare it with a pyogenic meningitis. How are the two things different? Pyogenic versus normal CSF picture. Few comparisons are there. Remember this appearance of the CSF. When I look at the CSF, how is it appearing in the test tube which I have sent to the lab? The appearance of a normal CSF is always clear, see-through and transparent. I can see through and through. While in a pyogenic, it's bacteria, it's going to be a pus forming thing. So it is going to become a turbid looking CSF. Apart from this, cell count that we know. Cell count, very important. Cell count in a normal CSF is always 5 or less than 5 cells. While cell count is going to be above 5 in pyogenic meningitis. And don't forget, the cell count rise in the CSF specimen has got a name with it as pleocytosis. So rise in the cell count in the any kind of CSF picture is known as the pleocytosis. Now my question will be for you guys. Apply your mind and tell me what is going to be more, neutrophilic or lymphocytic? In pyogenic, N or L? It's very simple. It's a simple guess. Yes, it's a pyogenic kind of a thing. It's going to be more polymorph predominant neutrophilic picture. Okay, it's very clear. Now, when I look into the protein content in the CSF, the normal protein content is in the bracket of 15 to 45 milligram per deciliter. The protein content in the CSF in pyogenic is going to move up. 2 arrows up I'm putting, it's going to go up. When I look into the glucose content, now this is something very important, the glucose content of the CSF. It is somewhere in the bracket of 40 to 70 milligram per deciliter. And there is a correlation that you have been taught in pathology also, that the CSF glucose runs 2/3 of the random blood sugar. Now don't ask me what is RBS, you're not that dumb. RBS stands for random blood sugar, okay, simple term. 2/3 of the RBS, the CSF glucose all the time runs like this, okay. So it's a dictum always when I look at the lumbar puncture, I'm doing an LP, always I should take the RBS of the patient with the glucometer strip at that point. Just imagine the RBS is low, the CSF glucose automatically will go low. So the CSF glucose is correlating with the random blood sugar of the patient at that moment, and it is 2/3 of the random blood sugar of the patient at that moment, okay. Now, apart from this, the glucose in patients of pyogenic meningitis found to be very, very low. Now, there are 3 arrows down for them. Very, very low CSF glucose is found in patients of pyogenic. Now, there's a term. Just remember this term. Low CSF glucose is known to me by a term hypoglycorrhizia. So just a term which we remember as hypoglycemia in low blood glucose. You've studied by Arvind sir in diabetes also. There's a term parallel going in the CSF glucose now. It's not hypoglycemia there, it's hypoglycorrhizia, right? Simple term. Another fact to be known is chloride. The normal CSF chloride runs in the range of 116 to 126 milliequivalent per liter. While the pyogenic is having a slightly low chloride level. It's slightly low, not very low, right? So these are few facts that I should know in a CSF picture, how to tell it's a pyogenic meningitis or not. Now looking into the treatment part. How do you go about treatment in patients of pyogenic meningitis? Remember this first thing, first and foremost thing. A patient has come in the emergency room to me with fever, altered sensorium, neck rigidity, headache, and all this thing going on. The very first thing I should offer the patient anytime is a steroid, dexamethasone. Now the dexamethasone that we give to the patient as steroid is 10 mg IV stat. Stat means the bolus of steroid that you give. That means the moment the patient comes with this clinical scenario, the very first thing I give him a heavy dose of steroid, dexa. Okay. Why do we give dexa first? Why don't we give an antibiotic? Because I'll tell you the fact. Remember this. Whenever the organism, any organism, a bacterial pathogen, when I look at bacterial pathogen is causing meningitis. Okay. In meningitis, there can be raised ICT, the intracranial tension could rise. Okay. And raised ICT in these patients commonly occurs due to cerebral edema. Why does cerebral edema in a pyogenic meningitis happen? Is it due to the bacteria causing a tissue injury or an inflammatory response? Remember this simple pathological fact. Cerebral edema in this patient is due to inflammatory response, which is caused, by what? Inflammatory response caused by the release of endotoxins or maybe certain kind of cytokines from the bacteria. Now this is a very, very important statement recently asked. Does the bacteria go and damage the brain cells? No. It is all drama coming because of the inflammatory response caused by the release of endotoxin from the bacteria. Now tell me, does the bacteria go there and release endotoxin on its own? No. Whenever the bacteria dies. Now who will kill the bacteria? Tell me. It's a natural immune system, one maybe, but that's not that workable in such a deep area. Who is going to kill the bacteria? It's a very simple concept. A meningitis patient has come to you and you found a cerebral edema kind of a thing coming in him. It is all due to the inflammatory response by the release of endotoxin and cytokines from the bacteria itself. Who is going to kill the bacteria? I know neutrophils are going to kill it. Bacteria is actually killed not by the neutrophils that much as you think. That means the neutrophil macrophages are going to kill it. No. Is or rather dead by antibiotics. So remember this. The concept is going like this. Yes, some people are answering me correctly now. Antibiotics are entering the central nervous system, which I am going to give to kill the bacteria. And this bacteria is going to be killed by the antibiotics. And killing by the antibiotics, not the neutrophils actually, is going to release a lot of endotoxin and cytokines. So why do we give steroid first? Look at this now. Look at the concept, please. Why do we give steroid first and then the first dose of antibiotic? Because if by chance a meningitis patient has come to me and I give him a shot of antibiotic first, the bacteria will be caught by it and now there is going to be a rampant rise in the inflammatory response. Please be careful. Please be careful. I've seen this in my ward duty once, and in turn I told him to do all these things and he just did the thing. He gave it Dexa and an antibiotic after 2 minutes. No. There has to be a gap of 20 minutes between the two. So first a steroid, then the shot of antibiotic is always good for the patient, because now the steroid will decrease the cerebral edema. Okay. And secondly, whatever edema, cerebral edema is going to come by the antibiotic, which also be taken up by the steroid body. Okay. Now, Remember this protocol. This is a very important statement. Antibiotic, the first shot with a steroid prior to it, should go into the patient within 60 minutes of arrival. That means a patient with fever, neck rigidity, altered sensorium has come in the emergency. I have not done the LP also, and now I should be giving the two things within 60 minutes of arrival. That means early treatment is always having a good prognosis in the patient. Correct? Regarding mannitol, I'm telling you this thing, in meningitis, the mannitol doesn't really work well. In patients of head injury or maybe any kind of a brain abscess, it could really work. Not in meningitis patients, okay? We do give mannitol, no doubt on this, but when you treat the etiology of this, the cerebral edema will also decrease, okay? Now, which meningitis, which antibiotic, this is important. We look at the organism that we are looking at and the particular treatment accordingly. The organism that we have with us is your meningococcal meningitis or Neisseria meningitidis. In that patients, remember this, I'll not confuse you too much in this. We give to the patient ceftriaxone straight away. Because in books, if you open up, there is a lot of controversy on this. Some people say it's penicillin sensitive or resistant. It's always better to give a ceftriaxone or third generation cephalosporin to these patients. It's always better. Given through the route IV intravenous for a duration of 7 days. Now, need not remember the doses and everything. Just remember the duration. That's very important. Okay. What after 60 minutes? After 60 minutes also you can give, no problem. See, it's better if you give it within 60 minutes of arrival. Okay. Then we have the pneumococcal organism. The pneumococcal organism, we need to give ceftriaxone, a third generation cephalosporin with vancomycin. Both of them. The ceftriaxone and vanco, both of them are given for a duration of 2 weeks or 14 days time. Right. So 2 antibiotics are to be given for pneumococcal. Now looking at this listeria, yes, this is something very important, listeria. For listeria organism, we can give one antibiotic, that is ampicillin. Now ampicillin this time is given for a duration of at least 21 days. So we have got listeria organism with us and we give ampicillin for them and it's given for a 20 days time. Okay. Some people were asking me about, sir, you did not tell about Staph aureus. Staph aureus. Now remember a point about Staph aureus as an organism related to meningitis. It is a very common cause of meningitis following any kind of a invasive procedure for the skull, of course, or maybe a shunt surgery that we do. Shunt surgery that we do. Okay, so any kind of a VP shunt that we have put in the patient or maybe in any invasive procedure, we always look for Staph aureus organism. Okay. Now, Staph aureus organism is well treated by nafcillin. Okay, we give nafcillin to these patients. Need not remember the doses, it's become very confusing for you guys. Remember this. Only few points have to remember here. Now, some people are asking me, sir, you're not done the LP and you're giving this antibiotic on your own. Yeah, most of them are given through the route IV. Of course, IV is not oral, it's a sick patient. So you need to give IV route. Now, which antibiotic as per which organism? See, patient came with meningitis, he is an altered sensorium. How are you going to do a lumbar puncture? It's very difficult and challenging job for the intern or any resident. So it's always better to decide the antibiotic as per the age of the patient. I'll ask you now this. That is empirical therapy. Now people are asking me about empirical therapy. There's an empirical therapy that we try in these patients. That means as per the age of the patient, we decide the organism and we go ahead with a particular antibiotic. Now please tell me, if it is a adolescent patient who has come to you with meningitis, okay, what organism or which antibiotic are you going to give? Adolescent patient now. Please tell me, for adolescent patient, which antibiotic are you going to give? Now, good. Ceftriaxone. Ceftriaxone is the ideal, the third generation cephalosporin is utilized in them, because in them the meningococcal happens to be the most common cause. Then we have the adults. In the adult population, you know, the most common cause was pneumococcal. So we given the patient ceftriaxone with vancomycin. Correct. Now, can you tell me about elderly people? Now, I'm not asking you only specifically about elderly people. What should I manage them with? Elderly people now. Should I give ceftriaxone vanco? Yes, in the elderly population, I know this fact. The most common cause is pneumococcal. But elderly people are also predisposed to one more thing. What? Yes, they are predisposed to what? Listeria. And to kill listeria, good antibiotic ampicillin will really help you out. So please look at the question MCQ which you are getting in front of you. They will always mention a particular age. And as per the age, you decide the empirical therapy in the patient. It's simple. There are a lot of things here in the books and in the data that we have. Need not go into that much detail. Only this much gyan is more than sufficient. Okay. I know there are a lot of doubts in your mind. So culture will come, this and that. So accordingly, culture report comes and you decide which organism, which drug. Culture sensitivity also comes and it will really help me out. Okay. Now, what do we know as a risk factor for meningitis? That means a meningitis patient comes to me, what is a risk factor for him? Or maybe a risk factor for poor prognosis. Okay. Remember this. Decreased level of consciousness, in the patient on admission. Now someone was asking me, sir, what is this altered sensorium? Is it loss of consciousness? Yes. Anyone who is drowsy is also altered sensorium. People who are unconscious again are altered sensorium. So if a meningitis patient on admission is drowsy and has got decreased level of sensorium, it's a risk factor for meningitis. Risk factor in the sense, okay, I should not put risk factor here. I should not put risk factor. Poor prognostic factor. Okay, that will be a better term to explain them. Second one is that the onset of seizure in less than 24 hours of admission. That means a patient has come to you with meningitis and within first day of admission you find the patient throws a seizure. It's a poor prognostic marker. Then maybe in the patient you get signs of raised ICP. That means the intracranial pressure is very high in the patient. It's a very young and a very old. So it can be an infant or elderly people. Is again a poor prognostic factor anytime. Young, very old, we always tell them it's not going to come out so well. And of course, delay in initiation of treatment. Delay in initiation of treatment. That's very important. Because that's why I'm stressing first 60 minutes of arrival, you should always be giving him a steroid followed by the antibiotic. Okay. In pregnant female and immunocompromised, okay, you can give ampicillin to them, no doubt. I'll come to that question. I've got a separate set of MCQs. I'll ask you there, don't worry. Then we have a CSF picture, something wrong in the CSF will again take me towards the possibility that this patient is unlikely to recover. They say the protein content is more than 300 milligram per deciliter. the protein content in the CSF is more than 300 milligram per deciliter. It's a very high CSF protein content. And again, the glucose in the CSF is less than 40 milligram per deciliter. So these are the two things in the CSF picture which will always tell me as a poor prognostic factor for meningitis. So you remember, pyogenic meningitis is a high yield topic. We every year get 1 or 2 questions based on this. That's why I've taken this topic slightly more slowly. Okay, don't forget this topic. It's going to come in the exam hall. Now coming on to another meningitis, which is a bacterial one. None other than your favorite friend, tubercular meningitis or TBM. Now that's a very important quotation, that the most common meningitis, okay, in India when I look at, is always a tubercular meningitis. So what happens is that one of my professors used to always tell me that tuberculosis is the national disease of our country. TB is a national disease, not COVID. After COVID goes away, TB will again come back with me. Okay. So most common meningitis in India is TB. Okay. Now, when I look at the neurotuberculosis, remember this. Neurotuberculosis, it has been divided into various types. The first type that we have with us is tubercular meningitis, which is of two types. It can be basal or it could be spinal. So it could be basal or spinal meningitis, that is a tubercular meningitis. Okay. Second one is a meningitis type or maybe a complication of tuberculosis in the brain. That is nothing but my tuberculoma. Tuberculoma. That is a big ring enhancing lesion. Okay. Apart from this tuberculoma, remember this, can be intracranial, that is inside the skull, or can come even rare to rare as spinal. So TBM is also in the base of the skull. Okay, basal meningitis will come to that concept, as well as spinal. Tuberculoma is also inside the skull and can go to the spinal cord also. Another one is your tubercular abscess. That is a brain abscess which is of tubercular etiology. Okay. So this is how we try to look at a patient of neurotuberculosis, which are seen like this. It can be a tubercular meningitis, basal or spinal, tuberculoma, intracranial or spinal, and tubercular abscess. There are 2-3 more types. We'll not go into them. Okay, poor prognostic you want to see. CSF picture of a pyogenic meningitis, the protein is above 300, glucose is below 40, is a poor prognostic marker. Okay. Now, when I look at a patient with pyogenic meningitis, how does it all happen? Remember this. In a patient of pyogenic meningitis, there is inhalation of the infective agent in the patient first. So the infective agent which is causing the disease is inhaled in the patient. Okay. Then this organism which is inhaled, it often multiplies in the alveolar spaces. So inside the lung it tries to multiply. After this, maybe a gap that we take for 2 to 4 weeks time. A gap of 2 to 4 weeks time occurs. This organism which has multiplied inside the lung will spread through the blood. That means we are going to have a hematogenous spread of the organism. Once it comes in the lung, organism multiply in the alveolar spaces, and within 2 to 4 weeks time it spreads all across lung. After this bacilli lodges itself in the central nervous system. Now remember this fact. When it comes in the central nervous system, it comes in the base of the brain to sit over there. It might spread everywhere, but the amount of this kind of a thing, which is the bacilli, is more dense at the base of the brain. Now what happens? Everything is all dependent on one thing, the immune system of the patient. Now look at this concept, the immune system of the patient. If the immune system of the patient is good, what would happen? Because of the bacilli lying over there, what happens? Now tell me, what kind of a liquefactive change do you get by a tubercular organism? What kind of necrosis do we get over there? Granulomatous or caseous, what kind? Initially I'm asking about. Yes, a caseous foci will appear, and this caseous foci that appears often resolves. Okay, because the immune system is good, everyone there catching it will eat it away and it will be gone. Total normal patient will be there. But we find this now. The immune system is less efficient, but still effective. Now look at this, he is less efficient but can work, it is still effective. In that particular stage, what will happen? A caseous foci will develop where the organism was sitting, okay, with an encapsulation around it. So that means there is a high possibility that this patient may remain dormant. I'm using the word dormant and silent with the disease because it's not encapsulated there. So what happens next? In that situation, we're going to have reactivation if patient is immunocompromised. That means if my patient's immune system goes down and the patient goes immunocompromised, then in that case the thing is going to flare up. Okay, so please remember this point. Tubercular meningitis, when the organism comes, it comes through the lungs, multiplies in the alveolar spaces, 2 to 4 weeks time, spreads through the blood, lodges itself in the central nervous system. Most of the bacteria we find concentrated at the base of the brain. Immune system is good, caseous foci will appear, resolve. Immune system is not good, caseous foci will stay with encapsulation because the macrophages are fighting at the periphery, it's going to seal it. Now the problem is it might get back to a disease proper if the patient is immunocompromised due to some reason. But if immune system is poor, if the immune system is poor, what are we going to have? Okay. If the immune system is poor, what are we going to have? The caseous material that was there, okay, the caseous material that we have is going to rupture and spread in the subarachnoid space. SAS stands for the subarachnoid space. Okay, and now we get a particular full-blown form of what? Tubercular meningitis. So remember, this TB organism is a common organism which infects a immunocompromised individual, and you should always think of a kind of a disease which is a tubercular meningitis in them. Okay. So this concept of pathology will really help me to understand the disease also. I'll come to that. Because when I look at the organism or maybe a tubercular meningitis, in them we find meningeal exudates. There are some collection in the meningeal layer which we find in them, especially at the base. So in the brain, at the base of it, we find a lot of collection there. SAS stands for subarachnoid space, subarachnoid space. Okay. Now, after this, there can be a vasculopathy also in these patients. Vasculopathy. Remember this, in vasculopathy, we find inflammation in the last part of the arteries that we know as the end arteritis. Now, can you tell me, if I have got end arteritis, that is the last part of the artery gets inflamed, what next in the patient am I going to get? What disease is going to come because of this end arteritis? That means the blood vessels are not flowing properly with blood now. Infarct. So infarct in the brain is not always a case of stroke. Okay. So what we have this, the infarcts in the brain are something which can happen due to an infective pathology also. Very important is tubercular meningitis. Okay. Apart from this, remember, you can also have a problem in these patients as what? Hydrocephalus. Why hydrocephalus will occur? It's a very common sense thing. CSF is flowing up and down. At the base of the brain, you got basal exudates maybe. The meningeal exudates are at the base. So they're going to what? Obstruct the passage of CSF. Obstruct the CSF flow. That is, CSF which is moving up and down will be somewhere stopped by it. Now coming on to this. In these patients, you can also develop a big ring enhancing lesion in the brain known as a tuberculoma. So remember, the TBM patient is a very tricky patient for me. There are a lot of things in the patient that we find abnormal and we need to deal with them. It's not only meningitis, they can be infarct, they can be hydrocephalus, they can be even tuberculoma in them. Okay. Now, how do we look into the picture? CSF analysis in a patient with TBM. We put the CSF in a test tube, and in the upper and the lower part of it, we find this. Can you tell me what I am trying to draw? Or maybe I'll show that image to you. I've got that image today. What is this? Yeah, one student has asked me genuine doubt, will pulmonary TB develop before meningitis? No, it's not always seen. You know, I have seen patients of TBM which had no lung lesions. Actually, what happened, it came in the lungs, went silent there, and now suddenly we found them having this problem. It's not always a, yeah, it's very good, you are all right. This is a typical cobweb appearance. There is a settlement of a lot of things at the upper and the lower part of the CSF when it is put into the test tube. That is nothing but your cobweb appearance. Cobweb appearance. Now, apart from the cobweb appearance, remember this, in these patients we find increase in the cell count known as the pleocytosis. And of course, you must be knowing this, it's a lymphocytic predominant picture most of the time because it's a chronic kind of an infection that we see in the patient. Along with this, in the patient, we find that the protein content has gone up with 3 arrows up. The glucose content will come down with just an arrow down, and the chloride content in them actually is found to be very, very low. So something very specific about pyogenic meningitis, don't forget this concept, is that these patients most of the time have got a very low CSF chloride value. Okay. Now, there are other tests also in the CSF that we can do and order in the patient to know the disease. One is ADA. You'll read in respiratory about this enzyme, ADA enzyme. It is a adenosine deaminase enzyme. Now, ADA enzyme estimation in CSF, okay, to know the disease proper, right? It's not very clear. So I'll always give ADA as a question mark. Question mark in the sense because somewhere we found that the studies and the trials done on ADA is not very satisfactory to tell is it good or bad, right? Why low chloride now? That's a good question. I asked the microbiology sir over here, sir, why does chloride go down in TBM? No book gave me that answer, and sir gave me. that actually the media, if you remember the medium in which the tubercular organism grows very well, is a Lowenstein-Jensen medium known as LJ medium. LJ medium. Now, if you go and read in the book somewhere, the LJ medium is happening to be seen as a chloride-rich medium. So maybe for survival, the tubercular organism requires a lot of chloride. So it takes it from the CSF and takes down the CSF chloride level. One possible reason. Now, lymphocytes are more in patients of tubercular because it's a chronic infection. So whenever a chronic infection is there, the lymphocytes are always more. Correct. Now the question comes in, sir, what should be the gold standard test to diagnose TBM? There are a lot of controversies of late on this. PCR, is it good or no? Or ADA, if at all found, is going to be high. What is a gold standard test? Remember, this is a line given in Harrison. We have to respect the Bible. Is the CSF culture. So CSF culture happens to be the gold standard test to diagnose this problem. Okay. Now, coming on to the treatment part, very important. ATT, anti-tubercular therapy, ATT. In patients of TBM is given for 12 to 18 months. Why such a long-term ATT is given to the patient? Now the point here is I was clear in my concept that the bacilli in a person whose immunological status is not efficient but still effective, the bacilli will live there for a longer time. In a dormant stage, it might reactivate if the patient gets immunocompromised suddenly. So a long-term ATT will always guarantee me one thing, is a lesser amount of reactivation of the bacilli. Remember this point. And don't forget to give steroids to these patients. Steroids are also important. But what is the main role of steroid in these patients? What is the main reason of giving steroids in this patient? What is there in the patient that will always, I'm fearing most? Yes, end arthritis. So steroids, whenever I give, I want to inhibit one thing which can happen in the patient, the vasculopathy or the end arthritis picture. Now, steroids normally in patients with tubercular meningitis are given for a duration of 2 to 3 months time. So don't worry, steroids are not going to make the person immunologically bad, but to some extent it is going to inhibit one thing which I am really fearing of, end arthritis. And don't worry, even the immune system goes down for some time in the patient. The ATT is already there now, so it is going to kill the bacteria. So don't worry. Infection won't easily flare up. See, what do we do in the patient? We give them steroid like prednisolone. We give them prednisone oral, 60 mg per day for a month duration, for example. And then we gradually taper it and decrease it and stop it in 2 to 3 months time. So we may not be giving all the time very heavy dose of steroid for a very long time. Some of the doctors give it for 2 to 3 weeks, that's also fine. So steroids are given to these patients, always given to these patients. Okay. Now comes another meningitis, that is viral encephalitis. Actually, it's not meningitis, it's virus encephalitis. Now, viral encephalitis is something which is a very common scenario. Remember this. There are a few MCQs related to it. The most common cause of viral encephalitis, right? The most common cause of viral encephalitis, overall when I look at, is always enterovirus. Correct. Now, most common cause of epidemic viral encephalitis that is spreading very fast is arbovirus. See, in TBM cases, I'll answer this query. Both of them are given simultaneously. Okay. It's nothing like steroid first then ATT. No. Both of them are given simultaneously. Sporadic means ectopic, not clear reasons when it happens, from where does it come, is HSV. Herpes simplex virus type 1. So HSV encephalitis is something which is most common cause of sporadic viral encephalitis. Now that's a topic to read. Arey Baba, ADA, you want to write the full form of ADA, something new you have heard suddenly, no? Adenosine deaminase. That's the full form of it. You'll read in respiratory and pleural effusion details on it. I don't want to go into that topic. Okay. Now, topic is HSV encephalitis, a very important topic. Common questions, easy question being asked on it. HSV encephalitis. Okay, why does ADA increase actually? So what happens is that in any kind of a tubercular infection, this enzyme activity often flares up because they are seen in the lymphocytes. So whenever more lymphocytes are there, this enzyme activity will always flare up. So it is due to some lymphocytic proliferation and a chronic infection which makes in a particular media, maybe fluid that is around the lung, pleural, ascitic or CSF, the ADA will go up. You'll read, don't worry, you'll read about this concept in respiratory. Okay. Now this happens in patients of herpes simplex encephalitis, that is hemorrhagic lesions. That is, lesions are seen in the brain somewhere with red dots all over. This is known as the hemorrhagic lesions. Okay. Now remember this, whenever the hemorrhagic lesions comes in the CSF, it is going to change the color of the CSF. And we have a typical picture of the CSF that is known as xanthochromia. Look at the name, xanthochromia. The word xantho stands for a dark color and chromia stands for the word color. So it's a dark looking CSF. If you remember, we started with this. The CSF was transparent, that was normal. It became a cobweb in TBM. It became turbid in pyogenic. Now in HSV encephalitis, it is dark colored. Why? Look at this. The hemorrhagic lesions will always give it as a red hue. That means whenever the RBC comes in the CSF, the RBC in the CSF will often make it look red. Correct? But sooner we find the color may turn yellow also. Yellow also. Why? Because the RBC which is there is going to metabolize or convert itself into a substance known as bilirubin. So what we find is somewhere the bilirubin coming into CSF will always make it, anything, it always turns it yellow. Simple. I'll show you some images related to it, don't worry. Okay, I got some images with me. Now look at this. I'll write it here. A, B, A. You can see the CSF. It's clear, clear, clear. It's a normal CSF. Normal CSF you can see is obviously clear. Right? The B one. The B image on this side, B, this one. The CSF color is looking very dark. It's a red looking CSF. The color is red because maybe blood has come in the CSF making it red. That is a concept of your xanthochromia again. Dark looking CSF, xanthochromia. But what is, I'll just zoom out this thing. What is C and what is D now? Look at C. The color, if you're not colorblind like me, I'm slightly colorblind, is a yellow looking CSF. That is also xanthochromia. But now what has come here? Like here it was an RBC. Here we have what? Bilirubin. Right? What is D? If someone tells me D, I will say, Umesh Patel has told me the right answer. Very good. First, second and the third while now. Look at this now. first vial, second vial and the third vial. The first vial it was red, dark red, it became light red, and now in the fourth vial it became clear. Yes. What is this? Very good. This is nothing but your traumatic LP, traumatic lumbar puncture. Very good. Now can you tell me a condition where the RBC stands red all the time? That means CSF looks red all the time. Can you tell me one condition which the test tube B you can connect with? Test tube B you can connect with. This is traumatic LP. Any guesses, any ideas on this? Yes, getting some answers from your end. Good. Subarachnoid hemorrhage, SCH. Subarachnoid hemorrhage has been a condition in which we get RBCs mixed in the CSF. Hemorrhage, subarachnoid. So look at a xanthochromic CSF. If the RBC from the first, second and the third vial is the same, it's SH. If it is a traumatic LP, the RBC content will slowly decrease like this. You should be aware of all these things. That's why third vial, remember the third vial is always taken for the cell count, because the RBC content in the third vial will be the least as compared to the first and the second vial that we collected for the CSF. I'll tell you my account. You know, even this traumatic LP, if the RBC lives there for a longer time, you know, it can change itself into bilirubin. Even SCH can happen. Look at this. This bilirubin pigmentation can happen even in SCH cases, because the RBC there for a longer time will turn itself into bilirubin and you can have this problem. Okay, because I remember my case. I remember this case when I was an intern. I was given a job to do an LP, and you know, interns are they are bahubalis. They are a rebel without a cause sometimes. And I went in with the LP. I poked the needle inside and reached the subarachnoid space. And in the very first prick, I punctured a vessel. And suddenly, in my test tube, this kind of thing came in red, red, and red. And I was very happily collecting it because it was a traumatic LP initially, in the first file at least. Okay. So when I was collecting this first file, RBC was coming. It was all red. And my senior resident who was looking after me, he asked me, okay, what are you doing? So I said LP. He said, no, you are doing blood sampling. There is only blood coming out. Don't do this. Learn the procedure and do this after 3 days. In the same patient, I'll look at you. So after 3 days, I went back to the patient again. I did an LP in him. And now to my surprise, the first prick that I did, the CSF came not red, neither clear. It came yellow. I was very happy because I did the LP in the first prick. Correct? But I saw a Foley's catheter running out in the patient with the urine having the same color yellow. Now, intern height of innocence, I thought I went into the bladder. Look at my heights of innocence, and I'm draining out the urine. So I really got scared. I started smelling the sample first of all. Now what happened? The senior resident behind me was laughing like anything. He said, sir, why are you laughing? He said, Arey gadhe. The RBC that you have left behind 3 days back might have converted itself into a bilirubin, and now the CSF that you are coming out is yellow. Simple. So sometime in traumatic RBC LP also you can have this kind of a picture. Simple. Moral of the story that day I learned was that I cannot approach the bladder from spine. It's always a suprapubic approach. It's anterior. Now apart from this, there is pleocytosis also seen in them. That's rise in the cell count. And remember this, it's a lymphocytic predominant picture than the neutrophilic. Now the protein content again goes up in them. And the chloride could be low slightly. Glucose is perfectly normal in these patients. Remember this concept. The glucose, CSF glucose, is very commonly normal in patients of HSV encephalitis. Right? Now, MRI is something which will always help me to find these patients out from the crowd. Remember this, you'll learn somewhere in your radiology classes also that bitemporal hyperintensities bitemporal hyperintensities are seen in patients of HSV encephalitis, right? And you'll read in detail about this in radio classes, don't worry. Just a word on treatment of HSV encephalitis is a drug known as acyclovir that we use. Now, acyclovir is given to them at the dose of 10 mg per kg through the route IV intravenous 3 times in a day, 8 hourly, for a duration of total 21 days. Earlier we used to teach like this, 14 days and then 7 days. Now the protocol has slightly changed. They give it all for all the patient for 3 days, 21 days. Okay. So that's about HSV encephalitis, a small but a relevant topic. Yeah, someone reminded me. Thank you for this. The most sensitive test to diagnose HSV encephalitis is PCR for HSV. PCR for HSV is something considered to be the most sensitive test to diagnose HSV encephalitis. Okay. Why is chloride known? Not clearly known, but books writes it like this. We have to take it. I do not get an answer for everything which I was a query sometime. Okay. Now let's move into another group of disorder which is known as progressive multifocal leukoencephalopathy. See, remember only one thing at your end. The tubercular meningitis is something which is going to have a very, very low CSF chloride. Now another interesting disease to read is PMLE. Very long name, no? Progressive multifocal leukoencephalopathy. Sounds like, no? Ranchor Das Shamakdar Chachar. Rancho. PMLE. Short and sweet name. Okay. Viral encephalitis, if I look at, it's a very simple thing. How do they present? It's a genuine question. So viral encephalitis, how do they present? Clinical features. It is again the same. It is going to be headache. Okay. It's going to be altered sensorium. Yes. And most important, seizure. So look at the triad for encephalitis now. We are not having neck rigidity in them. Got my point? So this is not meningitis. This is inside the brain encephalitis. So this is the three things that they commonly present with. Headache, altered sensorium and seizure. That's it. So not too much of clinical symptoms in HSV. There are only three things that we need to know. Of course, fever. I forgot fever here. How can I forget fever? With every itis, you get it as a prasad every time. Okay. PMLE is a very simple, clear concept. Why am I forgetting everything? I've become Gajni or what? Now, JC virus. You are always there to remind me, no? That's why I'm forgetting things. JC virus is something which is affecting two cell lineage in the brain. Remember this. One cell lineage is the oligodendrocytes. And the second cell lineage that we have with us is the astrocytes. See, we are actually running short of time. That's why I don't want to give break to any one of you. Just carry on. At your end, if you're having some synchrony problem, just shut down the app and restart it once. You'll have a clarity in this. Okay. Now, oligodendrocyte is something which is forming myelin, if you remember, in the central nervous system. Do remember this, that the JC virus actually goes and sits inside the oligodendrocytes. And when it goes and sits there, it has got certain bodies over there known as the inclusion bodies. So inclusion bodies is something which is formed inside the oligodendrocyte by the JC virus. Now, someone is asking me this here. JC. What does JC stands for? Yeah, you guys tell me. You read microbiology. I'm very poor in that. Yeah. What is the JC full form? Astrocytes. If you know the astrocytes are John Cunningham virus. Okay, so it actually Cunningham spelling. I just want you to know from you guys. That's why I asked you. John Cunningham. I'll write the spelling. John Cunningham. Sounds nice, like Bajirao Singham, John Cunningham. Yeah, nice names. God bless America. Now, astrocytes. Astrocyte is something which is the Avenger. Remember this. Why do I call it as Avenger? Avenger in the sense that they are having or forming a barrier known as the blood-brain barrier. So remember this. If the astrocytes are being affected, in these patients we are going to have disruption of blood-brain barrier. So do remember this. There is disruption of blood-brain barrier occurring in patients of PMLE. Okay. Now, please do remember this. Who are the hosts for this virus to come in? Who are the hosts which are more likely to be involved in these patients? Remember this group of people known as the immunocompromised hosts. So immunocompromised hosts are most likely to get affected by this disease. And you know the topper always for the immunocompromised is HIV positive patient. We learned somewhere that 80% of people with PMLE are found to be HIV positive. And most common or most vulnerable host to harbor the disease is always an immunocompromised host. Second group of people, remember them, is hematological malignancies. Hematological malignancy, not malignancy, sorry. Hematological malignancies. Another group of people is nothing but your transplant recipients. Could be even a chronic inflammatory disease. Possibly you know why the transplant recipients are immunocompromised, because to prevent graft rejection in them, a new organ which has been placed is known as a graft. To prevent the graft rejection, you put them on immunosuppressant lifelong. And don't forget this iatrogenic, drug induced iatrogenic. Now there are two drugs, don't forget the name. This is a very commonly asked question. One drug that we know is natalizumab. Another sister of natalizumab that we have is rituximab. So natalizumab and rituximab are the two drugs which are considered to lead on to this problem of PMLE. There's a lot of data being collected on this. Need not go into that much detail at your level. Only remember two things: natalizumab and rituximab are the two drugs which are associated with PMLE. Now, when I look into the clinical features of PMLE disorder, remember this: visual defects happen to be the most common presentation of these patients. The most common presentation of patients with PMLE is often a visual effect. Apart from this, in these patients you might also see mental impairment. The mental impairment could be in a form of dementia, confusion, or could be a personality change. So remember these few points. What are the clinical picture of in patients of PMLE? These are the few clinical pictures. And in these patients you can also have seizure disorder. But the moral of the story that you should always remember about this disease, which is very commonly asked question, what is the most common presentation in patients of PMLE? It's visual effects. Okay. Now, can you tell me where is this natalizumab used? A drug natalizumab is used in a demyelinating disorder of the central nervous system. Which disease am I talking about? A demyelinating disease of the central nervous system. Yes, your multiple sclerosis. Okay. Now, MRI is something which is going to find this problem very well. Okay. So remember just few points on this. In patients of PMLE, the MRI that we do shows areas of demyelination, that is loss of myelin, and hyperintensities. So whenever the infection happens inside the brain, the intensity of the signal on the MRI is going to rise. And look at this, when the oligodendrocytes are coming in and being attacked by the virus, the myelin loss also occurs progressively. So there is a demyelination and a hyperintense lesion seen in these patients. Okay. If on the MRI you're not able to diagnose it well, you can also look in for the CSF in this picture. Remember this, in patients of in pictures of CSF or PMLE, yes, actually there is no pleocytosis. In most majority of the patients, there is no pleocytosis seen in them. That means the cell count remains quite normal in them. Okay. But what are we going to look into the CSF? Can you tell me now? If I'm finding a normal CSF picture in them, what in the CSF I should look for to isolate the virus? Tell me please. Yes, that's nothing but your PCR. PCR for the JC virus is something that you should isolate in the CSF if you're suspecting this kind of a disease, right? Now, please remember, still not sure, then go in for a brain biopsy. So brain biopsy is something which comes the last. I'm putting an arrow with a reason because it comes last in the picture. Whenever I want to find them out, I find them out on MRI. Still not sure, go for the CSF. And the last thing that we try to do is the brain biopsy, if at all we are not sure of the disease. Treatment part, remember this, there is no effective therapy. Please don't forget, there is no effective therapy for these patients. There is nothing conclusive that we could find to do well in the patient. There is no effective therapy. But still, remember few names of the drugs which are under trial for these patients. Few names. One drug as a name that we get is mirtazapine. Another one, yeah, catching point, why no pleocytosis? Because the patient is immunocompromised. Good catch. So it's an immunocompromised patient who is more commonly affected by PMLE. So there is not a higher cell count which you can find, and most of the time it's quite normal in them. Yeah, brain biopsy is like Shraddhanjali to the patient. You do it post-mortem, not anti-mortem most of the time. Okay. I've seen patients of HIV with PMLE disorder. Most of them we catch them on MRI or as CSF analysis. Brain biopsy is something post-mortem for them. Mirtazapine is one drug which is used. Mefloquine is another one which is given to them. And cidofovir. So please remember this, that these are the few drugs that are under trial for this. Need not go into details, how do they really work, just know the names is more than sufficient. Okay. Now ART. ART. Now what is ART? It is HAART now. What is HAART? It is highly active antiretroviral therapy. Against HIV virus, we have antiretroviral therapy. Yes, we can try this thing on the patient. They found HART, if at all, is given to these patients, it most of the time improves the prognosis. And don't forget. Now, someone is asking me fever. In PMLE, please answer me. Patient is immunocompromised. He is having some infection by a virus which goes inside the brain, doesn't come into the meninges. Will fever be seen in the patient or not? Good question. Tell me the answer. Will fever really happen in these kind of patients or no? Yes, you got the answer, I think so. Whosoever is asking me. Unlikely. So that's why I did not mention fever at all, because the immunocompromised people, no. Now prognosis is bad. Since look at this, there is no effective therapy. Just giving a highly active antiviral therapy is going to improve the prognosis in them. So remember this, prognosis as such is death within 3 to 6 months of onset. Now find this name again. It is progressive multifocal leukoencephalopathy. It is increasing all the time. It happens at various points in the brain, multifocal. It affects the white matter where the myelin is seen in the brain, encephalopathy. It's PMLE. Simple disorder. Okay, someone is telling me inject the disinfectant. Fine, we'll do one day. When you go to America, you inject. Okay. Now let's go into another disease, that's a prion disorder. Again, I warn you, because these topics which I'm taking out are, I find them in the books very difficult to understand, even because a lot of data is given on them. Only few points need to remember. Protein and the glucose remain stable in them. See, all the viral, remember this way, all the viral problems affecting the brain, encephalitis, meningitis, most of the time, the glucose remains normal in them. So there's not a good variation. Prion. Prion disease is a disorder which affects the humans and animals both. I'll come to the details of it. Prion disease affects the human beings and animals both. And how is the disease different in each one of them? I'll come to your jokes also, don't worry. I'm having a good quality jokes. It should be a timing of comedy that should be proper. And suddenly I crack a joke, you will not laugh only. Okay, so there are some disease that we find, yes. CJD. What does CJD stand for? Can you tell me what does CJD stand for? Another disease that we have with us. Another disease that we have with us in human being is Gerstmann, Stroessler, Schinker disease. It is Creutzfeldt Jakob disease. CJD. Just wanted to check the spelling of Creutzfeldt once. Gerstmann Stroessler Schindler disease. Okay. GSS. Correct? I know the spelling very well. Since morning I'm trying to memorize the spelling of this disease. Another disorder that we have with us, yes, Kuru. See why I'm telling this, because this year in microbiology we got a question on this. Which of the following prion disorder is seen in human being? Which of the following is found in the animal species? So few names we need to remember. And this one is fatal, familial, insomnia. FFI. Okay. Animals. Now this is a question that was coming up. In animals we have got a disease which is known as a scrapie disorder, which affects the sheep population that we find. Another one is bovine spongiform encephalopathy. Bovine spongiform encephalopathy, known as BSE, abbreviated as BSE. So what we find is scrapie was seen in sheep. Bovine, as the word goes, it will go with the cattle. Yes. So there are two more. Leave that one. Just remember these two. More than sufficient. So just wanted to orient yourself to the names that we have. Creutzfeldt Jakob disease, CJD. Now remember this, why does a prion infection occur in us? And what's the whole drama behind this? Remember this, there is a gene or a protein with me that is known as PRP, which converts itself into PRPSC. Now the SC1 stands for scrapie this time. Now it was a disease which was discovered in sheep first. So the protein variant that came out from this PRP is a SC variant. Now PRP, what does this stand for? It stands for a prion protein. It converts itself into a PRPSC type. Now this PRPSC is going to cause one thing in the brain, neurodegeneration. Now please tell me what I am talking about. A normal protein changes its structure and becomes an abnormal protein that degenerates the cell where it is sitting in. What is this phenomena in journal path known as? What is this journal path phenomena known as? A normal protein changes its structure, becomes a defective protein. Okay, and this is the problem that we get in the patient. Not mutation. No. It's not mutation. No. It's not misfolding. It's not misfolding. I'll give you the hint. Here, more alpha chains are present than the beta. Here, more beta chains are present than the alpha chains. Yes, good. Some people are answering me correct. Amyloidosis. So there is a conformational change occurring in a protein. So the misfolding part, you are right over there, but it's not mutation actually. It's a misfolding part which occurs in the protein structure. Amyloidosis, that's a simple concept which causes the problem in them. Remember this, very important thing. In patients of prion, the DNA and the RNA sequence is typically absent. Now don't ask me where does this protein come from. The book clearly says the nucleotide segments which are coding for this kind of protein are not being inferred. Actually, we cannot find anything on them. Okay, we do not find any DNA RNA over there. Now, when I look into the CJD as a disorder, there are various types of CJD that we should know about. Okay, the first type CJD is known as sporadic CJD. Sporadic CJD, right? The second one is known as a variant CJD. The third type which we know is the familial CJD. And the fourth type that we have is the iatrogenic CJD. Why I'm telling this, because again this year I found a question, at least 2 questions came on prion sum in the exam. So that's a problem, you need to think about it. Sporadic CJD is found in 85%. Now when they ever ask you the most common type of Creutzfeldt-Jakob disease is known as sporadic. Now learn this word sporadic. The word sporadic means it's of an unknown origin. Where it is coming from, we are not very clear of. We did not put the word idiopathic just to fancy the term, we put the word as sporadic over there. The most common type is this. Now what is this variant CJD? Okay, just a word about variant CJD. Variant CJD was a disease occurring in young population. After consuming contaminated beef. So there were some spurts of cases which were documented somewhere in Europe that in the young population we found a CJD, and it is through the contaminated beef that they consumed anytime. Okay. Familial CJD is something which will occur in the family tree. Okay, that's the word familial coming with it. Now the gene mutation we need to remember, please. The gene mutation which is causing this problem is a PRNP gene which is located somewhere on the chromosome number 20. So remember a few points. It's a very heavy dose topic which I could read in the book, but some few points will really help you to remember and crack in the exam. Simple questions. The familial CGD comes to the family tree because a gene is there to form this kind of a problem, and that is PRNP gene located on chromosome number 20. Now this has been asked last year, iatrogenic CGD. Why does the CGD come into be iatrogenic now? One end I can get the CGD in me is by applying in myself corneal grafts. We have taken a corneal graft from a dead person and we transplant into a normal subject, and we can transmit the disease through the corneal graft also, iatrogenic. Now, please tell me, through the corneal graft, what other viral disorder can you transmit? What other viral disorder can you transmit through the corneal grafts? Any guesses? Yes, rabies, rabies. Good answer. So rabies virus is something which can be transmitted through the corneal graft apart from the this one, right? Herpes simplex, I know. I'm just asking you the thing that you need to remember, rabies. Corneal graft, EEG electrodes, dural grafts also can transmit it. Good. Even human growth hormone. Now this was a question. Human growth hormone. If someone is taking a growth hormone supplement from outside, which is derived from a human being who was affected by prion, obviously if I take that supplement, I might have this problem. That is iatrogenic CGD. Now the most common type, as I mentioned, was sporadic CGD. What few points about sporadic CGD? Sporadic CGD, the age of onset. Now age of onset in sporadic CGD, the most common type is taken as 66 years. So the age of 66 years is considered to be the age of onset for these patients. Now somewhere we find in them death occurs within 4 months of onset. That means when the person is catching the disease within 4 months, we see them dying because of the disease. Okay. Now, when I look into the clinical features of the sporadic CGD, we find various symptoms. They might come with dementia, correct? And of course, not to forget a movement disorder that I've shown you in the first class, myoclonus. A typical jerk occurs in them known as myoclonus. And don't forget, this myoclonus is known as a startle myoclonus. Whenever we test the patient, suddenly they jerk like this. That's a startle myoclonus, like a startle response in a kid. There are other symptoms also, need not remember that much. Just remember these two symptoms. Looking into the investigation part, yes, we do an electroencephalogram in them, EEG. Now, whenever I do an EEG in these patients, I find triphasic waves. Remember this name, triphasic waves on EEG. Now, what do you mean by the word triphasic? Look at this diagram. Either the wave on EEG that I read is going up or down, either up or either down. So it is going up and down in a phase. That is known as monophasic. Sometimes it goes up and comes down like this, up and down in a single cycle both. So I name this as what? Biphasic. And then what is triphasic? It is like this, going up, coming down, again going up. So this kind of a thing that we find is known as a triphasic wave. Okay. Okay, I'll just show you the previous slide that you were really worried about. CGD, the types is sporadic, variant, familial, and iatrogenic. Sporadic, most common, age of onset 66 years. Death occurs within 4 months of onset. Variant occurs in young population after consuming contaminated beef. Familial CGD, PRNP gene through chromosome 20. Iatrogenic corneal graft, EEG, dural grafts in human growth hormone. Clinical features are dementia, myoclonus, and these are the EEG waves that you find. But remember, in prion or CGD, if I look at, we're going to find a triphasic wave in them. Okay. On the brain biopsy that we try to do in these patients, remember this. The brain biopsy in these patients is going to form a pattern of degeneration seen in them, known as the spongiform degeneration. So remember this, a spongiform degeneration is seen in the brain in these patients. Just remember this name. Okay. Treatment. Again, I stress, there is no effective therapy seen in these patients. There is no good treatment available in these patients. There is no effective therapy. Okay. Yeah, EEG electrodes are placed superficially, but sometimes we have placed the EEG electrodes inside the brain. So you can write the name over here, intracerebrally placed. Inside the brain, we got the EEG electrode placed over there. So if they are placed over there, then inside the brain in a prion, it can go and transmit it to the other person. Okay, nothing specific in the CSF in them. Okay. Now another very small but important topic to read is neurocysteine sarcosis. May be discussed in microbiology also under the heading of an organism, that is brain biopsy. Sorry, not brain biopsy, parasitic infestation. Yeah, brain biopsy in prion CGD is spongiform degeneration. Just remember this word. Okay. NCC, when I see, is coming because of an agent. The name of that agent is nothing but what? Tinea solium. That is known as a pig tapeworm. Okay, pig tapeworm. Now, the hosts are there to carry on the disease. Yes. One host that we know is a definitive host. And the second host that we get is an intermediate host. Remember this concept, pig is always intermediate host and human being is always a definitive host. Don't forget this. Yeah, cooker. Some smell is coming to your end. My family members have started cooking food also. Oh. So I, intermediate, yes. Pig has got I, intermediate host, and definitive host is human being. Now, how do you get the disease? We get the disease into our circulation via consuming undercooked pork, one thing, or secondly can be contaminated raw vegetables. So many vegetables like cabbage and all that we have got planted in the farms, and we find them getting contaminated by this parasite and we get the disease. Okay. Clinical features, just a short list on this. Seizure. I'll not go into details of lot of symptoms are there, but most important or the most common clinical feature of patients with NCC is always a seizure disorder. Investigation. We're going to do a contrast enhanced study. Contrast enhanced study of the brain, that is CT or the MRI. And what do you find is a typical lesion like this. This lesion, as we know, is known as the ring enhancing lesion in the brain. So ring enhancing lesion in the brain is typically found in these patients. Okay. Also remember, this ring enhancing lesion passes through three kinds of stages, which have got different kind of cerebral edema surrounding them. Okay. Just remember this point. There is a stage that we find in NCC, very typical, is a vesicular stage. Second stage that we find in them is a colloidal stage. And the third stage that we find in them is a calcified stage. Okay. Vesicular stage is considered to be viable stage, live. V for viable, V for vesicular. Colloidal is a dying stage. And don't forget, this calcified stage is a dead stage. You'll cover this topic again in radiology, don't worry. How is it different from tuberculoma? You'll come to know in Sumesa's classes, okay? Vesicular stage, remember, has got cerebral edema. Colloidal stage has got maximum edema. And the calcified doesn't have cerebral edema. This is an age-old question, keeps on coming in. 3 stages: vesicular, colloid and calcified. Vesicular has got edema, colloid has got maximal edema, calcified doesn't have cerebral edema. Now my question for you guys is this. Tell me please, if I look at the patient of NCC who has come to me with seizure disorder, and now the radiologist might give me the staging, fine. Now please remember which stage you find the edema maximum, which stage you find the seizure maximum rather. Chances of seizure is highest in which stage of NCC? Yes, the colloidal stage, which is having a lot of cerebral edema. Okay. Vesicular can also have it. Calcified is going to be plus minus. Correct. So remember this, if a patient come to us with a seizure and NCC, we expect it to be a colloidal stage more likely. Okay. Treatment. Antiparasitic agent. There are certain drugs that we have with us which we can effectively give them to kill the parasite inside. Now this antiparasitic agent is nothing but your albendazole. Albendazole is given in these patients at the dose of 15 mg per kg per day. Just write this down, for a duration of 8 to 28 days. So albendazole is an antiparasitic agent of choice in them. It penetrates the CNS better, it is cheap, it is readily available everywhere, and it works very well then. Yes. Please remember, if you give albendazole, what extra thing do you need to give? If the albendazole is somewhere killing the parasite inside the ring enhancing lesion, yes, you need to give one thing extra. What? Steroids. And please don't forget what? The anti-epileptic drugs, AEDs. They are very important because the patient has actually primarily come to you with seizure. Now I'll repeat. People want some repetition in the previous slide. I'll come to that slide and ask you there. Please tell me albendazole as a treatment for antiparasitic cysticidal therapy. Which stage should receive it? I'll repeat this one. Vesicular viable, colloidal dying and calcified dead. The vesicular or the viable stage has got cerebral edema, colloidal stage has got more cerebral edema, calcified doesn't have it. Seizure is maximum in the colloidal stage because cerebral edema is maximum in the colloidal stage. Please tell me, albendazole, which stage do we give albendazole? Which stage? Yes, you are right. We need to give it in a vesicular stage, yes. Calcified stage? No. Dead. Colloidal stage, dying? A question mark. Why a question mark? It's all up to me. I want to give it, I don't want to give it. Question mark. Because it's a dying worm inside the brain, let it die naturally. Giving albendazole is going to create more problem with him. Okay. So as usual, the protocol as goes every time. We have to solve some MCQs. Right. See, I agree. CNS infection as a topic for a teacher also is very challenging because it's a very theoretical kind of a thing. I really cannot help you. There are a lot of facts over there. Yeah, Chutti will be announced on time. Don't worry. Okay. So, but still, I recommend you to read the notes properly on this topic because a lot of facts have been asked. Yeah, 78-year-old diabetic patient presents with signs and symptoms of meningitis. CSF examination shows picture of 100% neutrophils, glucose of 10, protein of 78. Look at the picture now. What is it? Please remember, it's always DEXA prior to antibiotics anytime. Because steroid first and the antibiotic. What kind of picture do you think it is? Neutrophil 100%, glucose so low. It's a pyogenic meningitis. Because someone told me, no sir, I'm not going to give steroid because the patient is diabetic. We can give insulin and maintain the blood sugar. There's no problem in that. Okay. Now answer me this one. 60-year-old alcoholic male comes with a fever, headache, decreased sensorium, neck rigidity is present, CT brain is normal, routine investigation is normal, LFT hemogram. Now CSF analysis shows 1000 WBCs, neutrophil predominant picture again, protein of 100 and a sugar of 20, hypoglycemia. What is the next step in management, my dear friend? Please tell me. A 60-year-old alcoholic male has come to you. You don't know which organism is it. The culture reports are still awaited. It's a case of pyogenic meningitis. At the age of 60, what are we going to do? Yes. Ceftriaxone with Vanco to cover up pneumococcal. But as per his age, you should always take care of listeria and give what? Ampicillin. Ampicillin. Right? It's an easy question. No problem. Some amaurosis fugax is occurring. Don't panic. Don't panic. All is well. I'm back. Now this is a clinical question that we need to just understand and discuss. A young male is diagnosed to be suffering with tubercular meningitis, TBM, and has started on ATT therapy for the same. 1 month later, the patient presents with worsening sensorium in spite of good compliance. Now look at the question. It's a patient of TBM given ATT for a month duration, and after a month he comes with worsening sensorium. That means the patient got drowsy in spite of good compliance of ATT. Now my question will be, what kind of a disease are you expecting now? Remember this, a patient on ATT can develop ATT induced hepatitis. If you know this term, hepatitis is inflammation of the liver, can be caused by a drug, ATT. If I remember, HRZ, the first 3 drugs of the intensive phase regimen are known to be hepatotoxic. They can cause it. Please tell me, which is the most hepatotoxic among the 3? Is it H, is it R, or is it Z? I'm asking you, the most hepatotoxic ATT among the 3. It is Z, pyrazinamide. Don't forget this pharmac question. Yes. Hepatitis anytime untreated, undiagnosed will lead on to what? Hepatic encephalopathy. Hepatic encephalopathy. Okay. Second possibility in this case, TBM is a stage of raised ICT. Remember this concept. Whenever you have a raised ICT problem, there is going to be release from the brain a peptide known as the brain natriuretic peptide, being abbreviated to me as a word BNP. Now whenever the BNP acts on the renal tubules, what it will do? As the name suggests, natriuretic. It will obviously take the sodium out into the urine. Now please tell me, if BNP acts on the renal tubule, what will happen? Decrease in sodium, hyponatremia. And if ever you have seen hyponatremic patients in the hospital, they are drowsy. Correct. This could happen in them. Number 3. This patient can develop a big ring enhancing lesion as a complication of TBM. I told you earlier, tuberculoma. Tuberculoma is a big ring enhancing lesion that can compress the neighboring structure, can have cerebral edema. Again, the patient can be drowsy due to tuberculoma. Fourth, possibly there can be obstruction of the passage of CSF, which I told you. Hydrocephalus. This can be another problem. Number 5, look at the patient please. He was only on ATT, not on steroids. So not on steroids can cause what? Yes, end arthritis. And if I look at endarteritis, it will cause ultimately what in the patient? Infarct. Right? So how do you find all these things? To look out for drug-induced hepatitis, you get the what? LFT done, liver function test. To look at low sodium, what do you get done? Serum, electrolytes. To look out for tuberculoma, what do you do? MRI. To look out for infarct in the early phase, what do you get done? Again the MRI. To look out for hydrocephalus, what can you do? A simple imaging, that is a CT scan. So this is how you approach this patient when you get him drowsy after a month of ATT therapy. Correct? Now answer my question. The question is, which of the following are justified as urgent investigation in this patient except what is not to be done urgently in the patient? Look at this please. Liver enzymes, if I look at, it is going to tell me about what? Hepatitis. Electrolytes are going to tell me about sodium. MRI is going to tell me about infarct. CT scan is going to tell me about hydrocephalus. Will the LP or the CSF examination help me? Not at all, in any sense. And look at the concept. Just imagine this. There was a tuberculoma up in the brain, correct? And I did an LP, took out the CSF, right? What would happen? What could happen? Please tell me. The CSF will come out, I agree, but the tuberculoma will come down, compress the brainstem, and this compression of brainstem you must be hearing here and there as a name known as coning. Coning, or I can use the word herniation, it's better, not coning, it's herniation. Okay, so if you do LP in this patient so early, urgently, you might land the patient onto some other problem. But students have their own answer. I tell you the students. One student told me, sir, I will get the MRI done. I said, why? Sir, MRI is not available in my hospital, that's why. That's your problem, not my problem. Some student told me, sir, I'll mark the answer as CT. I asked him why. They told me, sir, hydrocephalus, infarct, everything is found on the MRI. Why you want to waste money and time on CT? Look at this. The question is, which of the following is not justified to be done urgently? They're not asking you what should not be done, what cannot be done. What is not justified urgently is CSF. Correct. But a very intelligent student asked me a genuine doubt. He asked me this, sir. Sir, this patient had TBM a month back. Correct. Now this poor chap has got viral encephalitis or maybe a cryptococcal meningitis. Then you have to do LP to find this thing out, correct? So why not LP? I said, look at this question please. He is a young male. He is a healthy male. When do you suspect a patient of TBM catching more infections? Now please tell me. When do you suspect a patient of TBM catching more infections? They consider catching more infection when they're immunocompromised. Okay? Young male, correct? Young male is not immunocompromised. Who is immunocompromised? A truck driver. Okay? Don't write this please. And to understand the concept of truck driver, you should attend community medicine classes. You'll understand the concept there better. Okay. Now easy question. PMLE, which of the following is not involved? Which of the following area is not involved in PMLE patients? If you remember, the PMLE was a disease which was affecting the oligodendrocytes. Correct? And remember this, oligodendrocyte form myelin. Yes. In central nervous system, except for two areas. One is the optic nerve and the second one is the spinal cord. where their brothers Schwann cell are doing their work. So the answer becomes spinal cord. Simple. This question is not from medicine, it's from anatomy maybe. Okay, you know the answer. I'm really happy. Mogambo khush hua. And my apologies to hold you back, please. I'm really apologetic on teaching you guys. Sorry. Just joking here. Now look at this question. 45-year-old man recently moved from Delhi. He suffers with a focal seizure followed by a secondary generalization. If you remember that, he denies any symptom of active infection, has not suffered a recent trauma anywhere. His neurological examination has returned to normal in the emergency room. His MRI of the brain is done, shown in front of you. What is your answer? What is the next best step in management? Look at this lesion. It's a round, clear lesion, ring enhancing, with a lot of cerebral edema. What has happened? I taught you in the very first class. A discrete lesion will cause focal seizure, but the cerebral edema will make the seizure go everywhere. Yes, that is focal seizure with secondary generalization. That happened with him. Now, what is your best answer? Loxamide, if you don't know, it's an anti-epileptic drug. Some people don't know the name only. Vanco and Cefepime, you know, are the antibiotics, but they will really help me out in one condition: brain abscess. This is not a case of brain abscess. So out. Why is it not a case of brain abscess? Why? Look at the question again. He denies any symptoms of active infection. Correct? That means abscess cannot just overnight form like this. There have to be an active infection somewhere which will be coming as a sequelae of brain abscess. So out. Loxamide with biopsy of the lesion. Biopsy is too early, too crude. It's done post-mortem, we all know. Levetiracetam with acyclovir. Which condition do we use acyclovir? HSV encephalitis. Remember, you might see this again in radio classes that it's a bitemporal hypertension. It's not a ring enhancing lesion like this. So I'm not suspecting HSV. You all have answered it correct. I'm very happy. Albendazole. Because we suspect it to be a case of what? Neurocysticercosis. Someone asked me, sir, how are you so sure? I told him he has come from Delhi actually. That's why. Because Delhi and NCR region is considered to be an endemic zone for neurocystic circus infection. Even a lot of metro cities, Mumbai, even Bangalore has got this infection, very common there. Okay, and he has come from Delhi. As the saying goes, no, you can take a man out of Delhi, but not Delhi out of a man. Okay. So sorry. Okay. One student asked me, sir, when a student wants to read EEG, I said them, इतने भारी ज्ञान की जरूरत नहीं है. Remember this. Okay. So if you want to read EEG, leave that thing, please. इतने भारी ज्ञान की कोई जरूरत नहीं है. Because at your level, remember one thing. One thing you should be thorough, which Arvind sir started the classes with. What? ECG. Because in turn, holding an ECG in a hand is like this, holding a snake. Every time they hold it like this, what is going to happen? Okay. So, stay home, stay safe is a message again. So, that's the last meme. बुलाते हैं पर जाने का नहीं. Otherwise, you will have a lot of problems in your life. Any doubts on today's topic? I'll put a post on the Facebook. Wait for another 10-15 minutes. We can have a discussion on all the topics. Right. Change the time to 7 p.m. See, we have to respect some people who are fasting for the whole day. The sehri, the iftar time happens somewhere at 7. So it's very difficult. They might miss the first half an hour part. Don't worry, tomorrow most likely I'll take aphasia as a topic. That won't be that long. Okay. One topic which I could not do well today was cryptococcal meningitis. I'll take it tomorrow. Don't worry. Okay. Tomorrow's topic is aphasia. It's a very important clinical topic. So please come on time tomorrow morning 7:30. So not morning, sorry, evening 7:30. Okay. Right. So good food is cooking in my house. I'm really feeling hungry because they start cooking and I get the aroma. I'm like a Pavlov doggy who starts salivating every time. Okay, tomorrow topic is aphasia. We'll discuss that topic. It's a very clinical one.